Welcome to the 2020 Vermont Statewide EMS Protocol Update for the Advanced Emergency Medical Technician, AEMT, Medical Protocols. First, we'll review items that were added to the AEMT Scope of Practice in the 2019 National Scope of Practice Update: waveform capnography, epinephrine for cardiac arrest, IV Zofran, and parenteral analgesia for pain. Vermont AEMTs are already allowed to administer epinephrine for cardiac arrest. New scope of practice for Vermont AEMTs includes the use of waveform capnography versus just quantitative capnography. AEMTs will be pleased to know that IV ondansetron, or Zofran, has been approved. AEMTs will also have new options for parenteral analgesia, or pain control, including IV acetaminophen. Please note that we are not expanding the use of opioid narcotics to the AEMT scope of practice. Given our current opioid epidemic and the difficulty in securing this class of medications, it was felt that expanding the use of narcotics to the AEMT level was not a good idea. Please review the routine patient care protocol. Minor changes were made to clean up the protocol. Teaching language was trimmed out in favor of a more streamlined document. Language was added to patient approach to encourage the use of pediatric reference systems when treating pediatric patients. In the airway and breathing section of routine patient care, instructions for oxygen administration were changed to read: administer oxygen as appropriate with a target of achieving 94 to 98% oxygen saturation. This language reflects new thinking about oxygen. While we all know that too little oxygen, or hypoxia, is bad, we now also understand that too much oxygen, or hyperoxia, can also be detrimental. Too much oxygen can actually lead to oxygen toxicity and the production of free radicals, which can cause cell death, an inflammatory response, and vasoconstriction. Hyperoxia has been associated with detrimental effects to heart, brain, and pulmonary function. If the patient is in cardiac arrest or breathing is inadequate, go ahead and ventilate with 100% oxygen using a BVM. Otherwise, supplemental oxygen should only be administered as appropriate, with a target of achieving an oxygen saturation level of 94 to 98%, 88 to 92% in COPD patients. Note that lactated ringers may be used as a direct substitute for normal saline, except when administering certain medications. We have had some normal saline shortages, so this could come in handy. Lactated ringers, LR, should not be directly combined with the drug agents on this list. These medications should be administered at a site separate from where the LR is infusing via a normal saline lock or line, or stop the LR infusion for medication injection, then administer a saline flush, and then restart the LR infusion. AEMT should be aware of not using LR directly with atropine, diazepine, epinephrine, naloxone, or pralidoxine. Most of these other medications are only relevant to the paramedic. Nausea and vomiting, adult and pediatric. Yes, it's true, you spoke and we listened. AEMTs may now administer to adults ondansetron or Zofran 4 mg IV or IM in addition to the PO or ODT dosing. The IV solution, as previously, may also be given by mouth. The concern about administration of ondansetron has been that it can prolong the QT interval, leading to cardiac dysrhythmias. This is unlikely with the administration of only one dose. However, do not give ondansetron to a patient if the patient has a known prolonged QT interval on ECG. We have made some format changes to obstetrical emergencies. There is a new format separating out EMT, AEMT, and paramedic sections. In addition, a new section on preeclampsia and eclampsia was added. Please review the updated protocol. For preterm labor, AEMTs may administer an IV fluid bolus, typically 1 liter of normal saline. This may help reduce contractions, known as tocolysis, and prevent immediate preterm birth. Pain management adult. AEMTs now have a new option for treating acute pain: IV acetaminophen. Consider the administration of IV acetaminophen, 1,000 milligrams, in the adult patient. In addition, use of nitrous oxide continues to be an excellent pain management option for isolated extremity injuries, such as suspected fractures, or global soft tissue injuries, such as burns or road rash. Please review the list of contraindications to use of nitrous oxide. Nitrous should not be used in the patient with altered mental status or the multi-trauma patient. It is also not indicated for chest pain, headaches, or general abdominal or flank pain. The patient must be able to self-administer this medication. Remember, use of nitrous oxide requires approval of your EMS agency and local medical direction. Additional credentialing, use of a scavenger or ventilation fan and an open window in the patient compartment is required. IV acetaminophen was also added to the AEMT level for pediatric pain control. If only administering nitrous, IV access is not required. IV access is needed only if administering fluids or medications. Poisoning, substance abuse, overdose. We noted that in the previous version of our protocols, there was no specific mention of carbon monoxide, CO, in the poisoning section. Therefore, we have added CO toxicity to the protocol as it is a common form of both accidental and intentional overdose. CO is a colorless, odorless gas causing headache, dizziness, weakness, nausea, mental status changes, and the fatal triad of seizure, coma, and death. CO is also a myocardial depressant and can cause cardiac dysrhythmias. The field treatment for CO toxicity is continuous oxygen administration to help displace the CO molecules from where they are bound to hemoglobin in the blood. For suspected CO toxicity or isolated cyanide poisoning, apply 100% NRB face mask oxygen. These directions also appear in the smoke inhalation protocol. Many different types of overdose may lead to cardiac dysrhythmias. For any type of possible overdose, please acquire and transmit a 12-lead ECG if possible. Similar changes were made to the pediatric poisoning protocol. Septic shock adult. It remains important to perform a sepsis screen for all patients with suspected infection. If the patient has a suspected infection and 2 or more of the sepsis criteria, notify the receiving facility of a sepsis alert. There are some minor changes to instructions for fluid administration by AEMTs. Establish IV or IO access. Do not delay transport to start an IV or IO. AEMT fluid orders were changed to read, rapidly administer 0.9% NaCl up to 30 ml per kilogram bolus to maintain a MAP of greater than 65 or a systolic blood pressure greater than 90. Reassess the patient after each 500 ml administration, with special attention given to lung examination to ensure volume overload does not occur. The need to call medical direction for additional fluid orders was removed. Throughout the protocols, for adult patients, we are starting to emphasize the option to use MAP greater than 65, along with systolic blood pressure greater than 90, as a target blood pressure goal. It is slightly more accurate of an indicator. MAP can be challenging to calculate, but most monitors now report this value. No significant change was made to the pediatric septic shock protocol. Similar changes were made in the adult shock protocol regarding the use of MAP as an indicator for hypotension and AEMT administration of fluids to mirror that in the septic shock protocol. Smoke inhalation carbon monoxide poisoning. We changed the name of smoke inhalation to smoke inhalation/carbon monoxide poisoning. CO toxicity is commonly, but not always, associated with smoke inhalation. The name was changed to foster increased awareness of this connection. The patient should be removed from the toxic environment and 100% oxygen via non-rebreather mask or BVM should be applied. If a measuring device is available, obtain atmospheric levels of CO and cyanide. Consider use of CO monitors on first-in bags to assist in detection of occult CO toxicity. This is an important EMS provider safety consideration. Because CO toxicity can cause myocardial depression leading to acute coronary syndrome or myocardial infarction, it is important to acquire and transmit a 12-lead ECG if available. Finally, EMTs may now administer albuterol. If the patient has wheezing, consider administration of albuterol 2.5 milligrams via nebulizer. This may be repeated every 5 minutes for continued symptoms. As with any patient with altered mental status, always remember to check a fingerstick glucose by glucometer. We have also created an AEMT section in the smoke inhalation protocol. AEMTs are instructed to establish IV access and to consider CPAP for respiratory distress. This concludes the training module on the 2020 Vermont statewide EMS protocol update for the Advanced EMT medical protocols.